I'm Dr. David Binion from the University of Pittsburgh here at the Washington Digestive Disease Week meetings in 2018 with my colleague, Dr. James Lindsay from Barts Health in London, United Kingdom.
Yeah, and at this year's DDW in Washington, we reviewed abstracts on therapeutic patient monitoring and therapeutic drug monitoring. And so, David, what did you take away that's really going to affect your practice over the course of the next year?
You know, I think the whole concept of using objective monitoring of our patients to assess inflammation status has really come to the forefront in inflammatory bowel disease clinical care. And this meeting here in Washington, I think, had a wealth of abstracts and a lot of really impressive data that's going to help us employ therapeutic patient monitoring as a routine part of our practices.
And so what you're saying is that we need to do more than just look at patients' clinical symptoms. We need to be getting some objective evidence. And if I could press you then, what was the data, what was the evidence we needed, and what levels of that evidence should we be trying to get?
You know, I think some of the most simple studies that were carried out looked at markers that we're all really familiar with at this time period. An example is fecal calprotectin. Fecal calprotectin is easily obtained. It's a marker that gives us really insight into inflammation in the GI tract. And there was one study in particular that I thought was quite elegant. It was a study that came to us from Oxford in the United Kingdom, done by Alicia Walsh. And the study basically looked at cutoff values where fecal calprotectin was correlated with endoscopic remission and histologic remission. And that key number that we can take away from this meeting is a fecal calprotectin level that's below 180. We should be fairly reassured if our patients are having that type of a low fecal calprotectin level that they're actually going to be doing great.
So it has a wonderful negative predictive value. A low fecal calprotectin, less than 180, is great for saying the patients are going to be well. And I think the other study that I liked was the one from Chicago, from David Rubin's group, highlighting that fecal calprotectin really was very good at assessing ileal Crohn's disease activity, just in the same way as it was in colonic Crohn's disease activity, because that's been one of those unanswered questions over the course of the last few years.
So I think therapeutic patient monitoring is something that's coming to the forefront. But I would actually turn to you, Dr. Lindsay, to give us your insights about therapeutic drug monitoring and some of the new information that came from the meeting.
Absolutely. There were some really nice studies looking at therapeutic drug monitoring, and it's quite clear that this is going to become an important part of our practice. And I think the key message that came across to me was the importance with the anti-TNFs of using a therapeutic drug monitoring at the end of induction to predict subsequent response over time. Both with adalimumab and infliximab, drug levels seem to predict subsequent response, and therefore optimizing levels may improve outcome. I think it's harder with vedolizumab. It's clear that there's a exposure-response correlation, but the exact levels are not quite so clear. So I think for me, it was about induction dosing and induction therapeutic drug monitoring.
So I think some of the key takeaways from this meeting are the challenges that we all have with taking care of our patients with inflammatory bowel disease can actually be simplified if we turn to therapeutic patient monitoring with assays such as the calprotectin assay and therapeutic drug monitoring to help guide things moving forward.
Absolutely.
So Dr. Lindsay, it's always a pleasure.
Thank you.
Thank you so much.